Hello students. With this PowerPoint presentation, we're going to cover common lower gastrointestinal problems. The first being diarrhea. Diarrhea is defined as passage of 3 or more loose stools in a day. It's considered to be acute if this is lasting less than 2 weeks. Persistent diarrhea is more than 14 days, and then chronic diarrhea is more than 30 days or 1 month. The etiology is usually involves infectious organisms. So viral is going to be the most common cause, and then certain types of bacteria and then parasites are also common. But again, viruses most common cause of diarrhea. Clostridium difficile. This is usually a hospital-acquired infection. It's an infectious diarrhea, and it's quite contagious. If you care for a patient with C. diff, they will be on contact precautions and antibiotics, usually oral vancomycin or metronidazole. So manifestations of diarrhea, this you're probably pretty familiar with. You can have large volume, watery stools, bloody diarrhea, mucousy diarrhea. We do worry about dehydration and electrolyte imbalances, especially in the presence of prolonged diarrhea. As far as diagnostic studies, if this is something that's been going on for a while or is quite severe, we would want to obtain stool cultures, possibly even blood cultures to assess for sepsis, monitor white blood cell counts, monitor for anemia, especially if the patient's suffering from bloody diarrhea, and then also keep a close eye on the electrolytes. Treatment really just depends on the underlying cause. We want to hopefully prevent transmission and then maintain normal fluid balance and normal electrolyte levels. If your patient isn't tolerating oral IV or oral fluids well, we can do IV fluids. And then also protect the skin from breakdown. Diarrhea can excoriate the skin and increase the risk for skin breakdown. Our nursing actions, the anti-diarrheal actions. So these are going to coat and protect the mucous membranes. They help absorb any kind of irritating substance and kind of slow that intestinal transit. We just don't want to use these for too long because it can lead to toxic metacolon. So just kind of use them on an as-needed basis, sparingly, for a short duration of time. And then, of course, antibiotics. You can administer fluoroquinolones, azithromycin. This is going to depend on what type of infectious agent is the causing the problem. We talked a little bit about Clostridium difficile or C. diff earlier. Patients at high risk are those that are receiving antibiotics. Antibiotics kill the bad bacteria, but they also wipe out some of the good bacteria in our gut, which can increase risk of C. diff. Patients with chemotherapy, acid suppressing medications like proton pump inhibitors that we use for GERD. The stomach acid is one of the body's defense mechanisms. So if we're raising the stomach acid to a less acidic level, this can increase risk for infection. And the best way to prevent transmission is hand washing with soap and water. Talked a little bit about treatment, usually oral vanc, sometimes metronidazole or Flagyl. In very rare cases, there's actually fecal transplants that can be administered via like an enema, and it's thought to replace some of that kind of microbial environment with the good bacteria. But again, very rare. Usually for recurrent cases of C. diff, first-line treatment is going to be these antibiotics. So patients with diarrhea, we are going to consider all diarrhea infectious until proven otherwise. And really just hand hygiene is so important here. If you do have a patient with C. diff, remember they are going to be on contact isolation, which involves an isolation gown and gloves for everybody. And then to clean the room or surfaces, we are going to use bleach. Moving on to constipation. So constipation is defined as difficult or infrequent bowel movements, or feeling of incomplete evacuation. Acute is defined as less than a week, and then chronic is going on for more than 3 months. And then subacute is kind of in the middle of that time frame. Risk factors for constipation include low fiber diet, immobility, ignoring the urge to defecate, and even sometimes constipation can accompany anxiety and depression. Other risk factors, diseases that slow GI transit, certain maybe neurological conditions. We know about drugs such as opioids are notorious for causing constipation. So just keep that in mind. If a patient's on an opioid, probably a good idea to have them on a stool softener as well. Manifestations, so this can be anywhere from mild to severe discomfort. They might have absence of stools or maybe hard, dry stools that are difficult to pass. This can also contribute to abdominal bloating, distension, increased occurrence of passing gas. And if they're straining, they're going to be at a higher risk of developing hemorrhoids as well. We would also be concerned about fecal impaction and perforation in more severe cases of constipation. As far as diagnostic studies, usually your history and physical exam are going to be sufficient enough to diagnose this. This includes a thorough examination of the abdomen and perianal or rectal areas if indicated. But we want to gather data and assess their bowel habits for the last couple of weeks. If we're not sure what's going on, we can always get an abdominal x-ray, possible barium enema. These other diagnostic studies are for kind of ruling out other causes or differential diagnosis for constipation. Because again, usually we can, the healthcare provider will be able to diagnose this based on what the patient tells us. So to help a patient with constipation, we want them to increase their dietary fiber intake, so green leafies, getting plenty of those, drink plenty of water, about 2 to 3 liters of water a day, and exercise. They can use laxatives, stool softeners, enemas if needed, but we want to start with these kind of lifestyle changes first. So really emphasize vegetables, fruits, and grains. We talked about 2 to 3 liters of water a day, and also probiotics are good. That helps keep a normal level of the good bacteria in your gut. And we will stop here and move on to inflammatory disorders on the next PowerPoint.